Welcome to this lecture on type 2 diabetes mellitus, commonly referred to as T2DM. This is a chronic metabolic disorder that has become one of the most pressing public health challenges of our time. It is characterized by elevated blood glucose levels, primarily due to insulin resistance and a relative deficiency in insulin production. As the most prevalent form of diabetes, T2DM accounts for 90 to 95% of all diabetes cases worldwide. An estimated 500 million adults globally are affected, a number that continues to rise alongside increasing rates of obesity and sedentary lifestyles, particularly in developing nations. To effectively manage T2DM and prevent its serious complications, it is essential that we first understand its underlying pathophysiology. The pathophysiology of T2DM revolves around two primary defects: insulin resistance and beta cell dysfunction. Insulin resistance refers to the reduced sensitivity of peripheral tissues, such as muscle, fat, and liver, to the actions of insulin. In muscle and fat cells, insulin resistance impairs glucose uptake, preventing these tissues from absorbing glucose from the bloodstream efficiently. In the liver, insulin resistance results in inappropriate and excessive glucose production, further elevating blood glucose levels. Initially, the pancreatic beta cells attempt to compensate for this resistance by increasing insulin secretion, maintaining normal glucose levels in the short term. However, over time, this chronic overstimulation leads to beta cell dysfunction and eventual failure. This progressive decline in beta cell function is the central mechanism driving the rise in blood glucose and the clinical onset of T2DM. The role of adipose tissue in the development of insulin resistance is highly significant. Adipose tissue releases inflammatory cytokines, including tumor necrosis factor alpha and interleukin-6, which directly exacerbate insulin resistance in peripheral tissues. Additionally, adipokines such as adiponectin, which normally enhance insulin sensitivity, are substantially reduced in obesity. This reduction further contributes to worsening insulin resistance. Ectopic fat deposition, the accumulation of fat in non-adipose tissues such as the liver and skeletal muscle, also impairs insulin signaling pathways. Together, these processes create a vicious cycle of worsening insulin resistance and progressive beta cell dysfunction. Genetic factors further influence both insulin sensitivity and beta cell function, which explains the well-recognized familial clustering observed in T2DM cases. Diagnosing T2DM involves specific glycemic criteria established by the American Diabetes Association. A fasting plasma glucose level of 126 mg per deciliter, or 7.0 millimoles per liter or higher, qualifies as diagnostic. Alternatively, a 2-hour plasma glucose level of 200 mg per deciliter or higher during an oral glucose tolerance test, or an HbA1c level of 6.5% or higher, are also considered diagnostic thresholds. Screening for T2DM is recommended for all adults aged 45 years or older. It is also advised for younger adults who present with risk factors such as obesity, a family history of diabetes, a sedentary lifestyle, or a history of gestational diabetes. Early identification and timely intervention are crucial in preventing or delaying the progression of T2DM and its associated long-term complications. Lifestyle modification is the cornerstone of T2DM management. Patients are encouraged to achieve a moderate weight loss of 5 to 10% of their body weight, as even this modest reduction can produce meaningful improvements in insulin sensitivity and glycemic control. Regular physical activity of at least 150 minutes per week is strongly recommended, as exercise improves glucose uptake by muscle tissue independently of insulin. Dietary changes are equally important, particularly reducing refined carbohydrate and sugar intake while increasing dietary fiber consumption. These combined lifestyle changes can significantly improve insulin sensitivity and glycemic control, reducing the risk of both microvascular and macrovascular complications. For many patients, structured lifestyle programs can delay or even prevent the need for pharmacological therapy, particularly in the early stages of the condition. Pharmacological therapy is often necessary to achieve glycemic targets when lifestyle measures alone are insufficient. Metformin is typically the first-line medication, as it reduces hepatic glucose production and improves insulin sensitivity with a well-established safety profile. If metformin alone proves insufficient, additional medications are selected based on individual patient characteristics. Sulfonylureas stimulate insulin secretion and can be effective, but carry a risk of hypoglycemia. DPP-4 inhibitors enhance incretin effects, promoting insulin release in a glucose-dependent manner. SGLT2 inhibitors promote urinary glucose excretion and offer significant cardiovascular and renal protective benefits, making them particularly valuable in patients with established heart disease or kidney disease. GLP-1 receptor agonists not only improve glycemic control but also promote meaningful weight loss. As beta cell function declines over time, insulin therapy becomes necessary for many patients to maintain adequate glucose control. Chronic hyperglycemia in T2DM leads to a range of serious microvascular complications, affecting small blood vessels throughout the body. Diabetic retinopathy is the leading cause of blindness among working-age adults worldwide, resulting from damage to the blood vessels of the retina. Diabetic nephropathy is the leading cause of end-stage renal disease globally, causing progressive loss of kidney function over years to decades. Diabetic neuropathy, affecting peripheral nerves, can lead to numbness, pain, foot ulcers, and in severe cases, limb amputations. These microvascular complications arise from prolonged exposure to elevated glucose levels, which damage the walls of small blood vessels and impair their function. Achieving and maintaining good glycemic control is the most effective strategy for preventing or slowing the progression of these devastating complications. In addition to microvascular complications, T2DM significantly accelerates macrovascular disease, affecting large blood vessels. Accelerated atherosclerosis is a hallmark of T2DM, substantially increasing the risk of myocardial infarction, stroke, and peripheral vascular disease. Cardiovascular disease remains the leading cause of death among people with T2DM. Hypertension and dyslipidemia frequently coexist with T2DM, compounding the cardiovascular risk and necessitating aggressive management of all risk factors simultaneously. Effective management therefore requires not only glycemic control but also blood pressure management, lipid-lowering therapy, and antiplatelet treatment where indicated. An integrated, multifaceted approach targeting all modifiable cardiovascular risk factors is essential to reduce the substantial burden of macrovascular disease in patients with T2DM. Emerging therapies for T2DM are focused on several exciting frontiers. Research is targeting the preservation of beta cell function in the early stages of the disease, aiming to slow or halt the progressive decline that characterizes T2DM over time. Novel mechanisms for improving insulin sensitivity through anti-inflammatory pathways are also under active investigation. Personalized medicine approaches, utilizing genetic profiling and biomarkers, aim to tailor therapies to individual patient characteristics, potentially transforming outcomes by matching treatments to the precise biological profile of each patient. On the technological front, closed-loop insulin delivery systems and artificial pancreas technologies are being developed for patients requiring insulin therapy. These systems continuously monitor glucose levels and automatically adjust insulin delivery in real time, offering the potential for far more precise and effective management than current approaches allow. Type 2 diabetes mellitus is a complex, progressive, and multifaceted disease that demands comprehensive management. This management must simultaneously address glycemic control, cardiovascular risk reduction, and sustainable lifestyle modification. Healthcare providers must possess a thorough understanding of T2DM's pathophysiology to effectively tailor therapy, anticipate complications, and prevent long-term harm. Patient education and shared decision-making are essential components of successful outcomes. By empowering patients with knowledge and actively involving them in their treatment plans, healthcare providers can foster better adherence to management strategies and improve quality of life for those living with T2DM. As research advances and new therapies emerge, the goal remains clear: to reduce the burden of this condition and enable patients to live longer, healthier, and more fulfilling lives.